So what exactly is the crucial anatomical link connecting a strict 20-year vegetarian diet to progressive ataxia and, ultimately, irreversible spinal cord damage? As clinicians, we're constantly on the lookout for metabolic deficits that essentially masquerade as purely neurological disasters, right? It's a classic, high-yield clinical scenario, but one that is remarkably easy to miss if you don't know exactly what you're looking for on an MRI or right there at the bedside. So, welcome to this explainer. Today, we're diving deep into a highly reversible, yet frequently missed neurological emergency, subacute combined degeneration. Let's decode its diagnostic signature together just to make absolutely sure we never miss this condition on the wards. Here's a quick look at what we're covering today. We'll start with a clinical patient vignette, move into decoding the inverted V, break down the pathophysiology and anatomy, go over bedside assessment and differentials, discuss management and clinical pitfalls, and finish up with the resolution and a quick board review. All right, part 1, the clinical patient vignette. Let's meet Arvind Bhatia. He's a 52-year-old male presenting with progressive leg weakness over the last 3 months. He's got an unsteady gait that gets noticeably worse in the dark, plus numbness and tingling in his hands and feet. Now look closely at his patient profile. He has a history of chronic alcoholism and has been a strict vegetarian for 20 years. On exam, he's Romberg positive, vibration sense is absent bilaterally, and his power is 4 out of 5 in the lower limbs with upper motor neuron signs. And guys, his labs are literally screaming at us. We're talking an MCV of 112, indicating severe macrocytosis, significantly elevated homocysteine and methylmalonic acid, or MMA, and a profoundly low vitamin B12 level of just 78 picograms per milliliter. So with his MRI pending, we've got a highly suspicious clinical picture on our hands. Moving to section 2, decoding the inverted V. You absolutely must burn this image into your memory. Look at this axial T2 MRI of the cervical spine. Right there in the dorsal aspect of the cord, you can see this striking bright hyperintensity forming a very distinct V shape. This is the classic inverted V sign. It definitively indicates posterior column and often lateral column pathology. This is the radiological hallmark that links Arvind's low B12 directly to his sensory ataxia, firmly confirming subacute combined degeneration. It's a truly reversible neurological condition, which, let's be honest, is a rare treat for any clinician. One MRI pattern, one clinical exam, and boom, a diagnosis you will never miss again. But, seeing a bright spot on an MRI can definitely trigger a few different cognitive pathways. If you immediately jump to pathway A, assuming it's a multiple sclerosis plaque and referring out to neurology, you're working with an incomplete picture. And if you jump to pathway C, suspecting cord compression and ordering an emergency decompression, well, that's a seriously dangerous clinical error. The crucial move here is pathway B, recognizing that inverted V pattern of subacute combined degeneration, checking the B12, and immediately starting replacement therapy. Pattern plus location plus clinical context equals your diagnosis. The inverted V completely seals the case. Section 3, Pathophysiology and Anatomy. Let's actually map out exactly what we're seeing on that MRI. The posterior columns are divided into 2 main tracts. Medially, we've got the fasciculus gracilis. This transmits signals from T7 and below, so the lower limbs and trunk. Damage here perfectly explains Arvind's Romberg positive stamping gait. Then, laterally, we have the fasciculus cuneatus, which transmits from T6 and above, covering the upper limbs. When this tract is involved, you're going to see clumsy hands and a positive Lhermitte sign. Remember your pathways. These carry vibration, fine touch, and proprioception, traveling all the way up to the medulla before decussating. So how exactly do we get from a dietary deficit to a demyelinated cord? It follows a specific cellular cascade. Step 1, B12 deficiency, which could be caused by a strict vegetarian diet, malabsorption, or pernicious anemia. Step 2, without B12 acting as a crucial cofactor, biochemical markers like homocysteine and MMA start elevating in the blood. Step 3, and this is the absolute critical failure point, B12 is strictly required for methionine synthesis. Without it, myelin-basic protein simply fails and cannot be maintained. Which brings us to step 4, cord demyelination. The posterior columns are affected first and most severely, giving us that bright T2 inverted V signal. Okay, section 4, bedside assessment and differentials. Your sensory ataxia toolkit at the bedside relies on 4 key maneuvers. First up, Romberg's test. The patient absolutely must close their eyes. If they sway or fall with eyes closed, proprioception is lost. Second, vibration sense. Listen, you must use a 128 Hz tuning fork for this, not the 256 or 512 that we use for hearing. Check it distally at the medial malleolus. If it's absent there but present proximally, you've got a length-dependent loss, which is totally typical of SCD. Third, check joint position sense at the great toe. And fourth, Lhermitte sign. Have the patient flex their neck forward. If they feel an electric shock sensation traveling down their spine, that basically screams posterior column demyelination at the cervical level. It's incredible how we can directly map these bedside findings straight back to our MRI structure. The damaged posterior columns are what caused the positive Romberg, the impaired proprioception, and that bilateral symmetrical sensory loss. Meanwhile, the lateral column involvement is what gives Arvind those spastic upper rotor neuron signs. And since this is predominantly a cervical lesion, we get that positive Lhermitte sign. Notice how the anterior horns are spared? That's exactly why there is no flaccid weakness initially. Now, of course, SCD isn't the only cause of posterior column issues out there, so we really need to master this differential matrix. Subacute combined degeneration gives you the inverted V and macrocytosis. But definitely beware of copper deficiency. It looks radiologically identical, so always check for zinc excess or a history of gastric bypass. Then you have tabes dorsalis, which causes posterior column atrophy, not the bright inverted V. Friedreich's ataxia features both cord and cerebellar atrophy and usually strikes patients under 25. And MS, for that you're looking for asymmetric plaques, a relapsing course, and CSF oligoclonal bands. Section 5. Management and clinical pitfalls. Let's put this into context, particularly for those practicing in environments like India. Consider this. 65 to 70% of the Indian population is vegetarian or vegan. Combine that dietary baseline with widespread metformin use for type 2 diabetes, which, as we know, depletes B12, and throw in undiagnosed pernicious anemia in the elderly. What do you get? A massive population at risk. Plus, MMA and homocysteine tests, not to mention expensive MRIs, are often completely unavailable in Tier 3 labs, which delays diagnosis. So your biggest practical takeaway here? Suspect B12 first in any vegetarian presenting with ataxia and rely heavily on your 12/8 Hz tuning fork and Lhermitte sign to guide your clinical judgment early on. So once you suspect it, you need to implement the SCD management protocol immediately. Phase 1 is all about immediate injection. Hydroxocobalamin 1,000 micrograms intramuscularly daily for 7 days straight. Phase 2 then transitions to weekly IM injections for 4 weeks. And finally, Phase 3 is lifelong monthly IM injections if the root cause is malabsorption, or daily oral cyanocobalamin if the cause is strictly dietary. And don't forget adjunct therapies. Things like physiotherapy for gait retraining are absolutely crucial for a full recovery. But listen up, because this is where clinicians can make disastrous mistakes. Calling it MS without even checking the B12? That will delay treatment and cause irreversible damage. Missing the Romberg test just because you forgot to have the patient close their eyes is another really common physical exam failure. But the absolute fatal flaw? Giving folic acid alone. It is literally the quickest way to guarantee an irreversible neurology consult. Never give folic acid without B12 if the B12 is not yet corrected. Why? Because folate will step in and correct the macrocytic anemia, effectively masking the hematological findings, while simultaneously allowing the demyelination and neuropathy in the spinal cord to rapidly silently worsen. Finally, Section 6, Resolution and Board Review. Arvind's journey is fantastic proof that SCD is a highly reversible cord disease if you just catch it early enough. On day 1, with the inverted V confirmed, we started him on IM hydroxocobalamin. By week 2, his paresthesias were already improving and his Romberg sway was reduced. At month 1, his gait was noticeably steadier and his MMA levels had completely normalized. By month 3, a repeat MRI showed that bright T2 posterior column signal was actually fading away. And by month 6, Arvind had a near full clinical recovery, returned to work, and was simply placed on lifelong maintenance B12. All right, let's test your diagnostic reflexes with a classic board-style vignette. A 55-year-old vegetarian presents with progressive unsteady gait that is worse in the dark. He falls when asked to stand with feet together and eyes closed. MRI T2 axial shows bilateral posterior column hyperintensities forming an inverted V shape. What is the most likely diagnosis? Are we thinking multiple sclerosis, subacute combined degeneration, Friedreich's ataxia, or tabes dorsalis? If you've been following along with us, you know without a doubt the answer is subacute combined degeneration, the vegetarian diet, the dark worsening ataxia, the positive Romberg, and that pathognomonic inverted V sign make it completely undeniable. Oh, and here's a quick bonus board fact for you. If the MRI shows the bright signal extending out to include both the posterior and the lateral columns, it forms what is known as the Trident Sign.
So, as we wrap up this explainer, I want you to walk away remembering the ultimate sensory ataxia triad. First, see the inverted V on the MRI. Second, trust your tuning fork and thoroughly test proprioception at the bedside. And third, replace the B12 early and aggressively. And seriously, never ever give folic acid alone. The next time a patient presents with progressive clumsiness, will you be the one to recognize the subtle signs and reverse their spinal cord damage before it's too late? Keep your tuning forks ready, and I'll see you in the next explainer.